Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from SOBI.
Hello, I'm Maria Elisa Mancuso, Adjunct Clinical Professor at Humanitas University in Milan, Italy. Welcome to this program titled The Molecular Nuances of Hemostasis, Differentiating Factor VIII and Non-Factor Replacement. Joining me today is Professor Yassine Dargaud, Professor at the National Reference Center of Hemophilia in Lyon, France. Welcome, Professor Dargaud.
Hello, it's a pleasure to be here.
So, we will talk about hemophilia treatment. And in the last decades, we witnessed a very large revolution, I would say, in the treatment of this disease. Because treatment has advanced with the development of non-factor therapies, which target different sites in the coagulation cascade at variance with factor VIII, and have varying mechanism of action. And in this slide, in this graph, you can see that we have a group called factor VIII mimetics. They are monoclonal antibody mimicking the cofactorial function of factor VIII. But then we have a group of new molecules, basically monoclonal antibody or small interference RNA, which target natural inhibitors of coagulation. So in a way, we are rebalancing hemostasis to get into thrombin generation, as we naturally see with the activation of factor VIII. So let's say that we can get to the fibrin clot in very different ways. And these ways matters because if we compare the mechanism of action of those different molecules with factor VIII and the activation of factor VIII, there are some crucial points where they differ. Factor VIII naturally binds to activated factor IX in order to get factor X activated and then to generate thrombin. But what is needed in this physiological function is that factor VIII need to be on a surface, basically phospholipid surface like the platelet one, to colocalize factor IX and factor X. All these mechanisms are very well harmonized. And they are mimicked by factor VIII mimetics, which are monoclonal antibody able to bind as well factor IX, factor X, but with less specificity, but still getting into factor X generation and thrombin generation, and finally to the formation of a fibrin clot. Rebalancing agents, they end up in the same way. They enhance thrombin generation, but working on the other side, I would say, of the coagulation cascade. So by inhibiting natural inhibitors, in our case, by now, the major target recognized from therapeutic drugs are TFPI, so tissue factor pathway inhibitor, and antithrombin. So in a way, reducing the action of such natural inhibitors, it's possible again to enhance factor X activation, thrombin generation, and the formation of fibrin clot. However, with the availability of these multiple new therapy, some challenges, clinical challenges, remain for people living with hemophilia. And we have to recognize that over time, we always relied on levels. Levels matters, and we recognize from the natural model that having severe, moderate, or mild hemophilia already was a huge difference. And in the clinical phenotype, we know that moderate and mild patients, they still bleed, but they bleed in a very different way as compared with severe. And we also recognize that getting into the non-hemophilia range should be the ideal goal for every treatment in order to abolish ideally all possible bleeds, including those who are not clinically evident. That's why we always thought that being in the non-hemophilia range could have been the dream for everyone. But with the different drugs that we had at our disposition in the past, it was not always possible. Nowadays, we can talk about normalization of hemostasis and going into the non-hemophilia range because the new therapies allow us to be a little bit more ambitious and really target these as a realistic goal to treat our patient. This has also a very strong impact not only on the clinical side, meaning that we can abolish bleeds, but also on all the consequences, which are clinical, but also non-clinical, as improving quality of life of patients with hemophilia. And we learned by experience that patients with non-severe hemophilia may also experience, let's say, consequences on the natural history of the disease. In other words, we were used to observe development of chronic arthropathy very early in patients with severe hemophilia. And we were in the past convinced that this was not an issue for patients affected with non-severe hemophilia. Then we had to recognize that this is not true, because also people affected with non-severe hemophilia experience bleeds, maybe late in time and late in life, and it's just a matter of time that we can still see arthropathy also in this patient population. That's why we recognize the value of not really transforming a severe patient in a mild one, but really going a little bit forward and aiming at the non-hemophilia range for all patients with hemophilia. And if we look at the possibility to maintain such level with the therapies that we have in our hands nowadays, the question could be, is that possible to do that? It is, theoretically with all drugs, but in real life, if we look at the different PK, so the pharmacokinetics of those drugs, it's very hard to maintain levels in the non-hemophilia range with standard half-life products. We achieved a little bit more with extended half-life products, but the big step forward in looking at replacement therapy has been done with the advent of the ultra-long half-life factor VIII product, efanesoctocog alpha, because thanks to this product, for which the PK is completely uncoupled from the ceiling effect of binding with von Willebrand factor, it is possible to maintain such levels for a prolonged time in a week, so let's say 4 to 5 days in a week. And this, of course, matches with the good clinical outcomes. Gene therapy can provide time in the non-hemophilia range, but unfortunately, this treatment approach is not for all. And also, this kind of effect in hemophilia A tends to be not completely long-lasting for everyone. So there is a sort of decline in levels over time, and so patients may experience to go back to the mild hemophilia phenotype after some times. With non-replacement therapy, it is possible to increase and improve thrombin generation. However, the fact that we cannot really estimate precisely which is the activity of such drug as we do with replacement therapy led us to be a little bit more doubtful about what we are gaining in individual patients. So now we will look at some animations which show how the different therapies achieve hemostasis in hemophilia A.
So indeed, factor VIII is one of the major proteins of the coagulation system. And in patients with hemophilia A who present a factor VIII deficiency, thrombin generation is dramatically impaired. In these patients, the initiation phase of coagulation is largely preserved because factor VIII is not really involved effectively in this phase. But the propagation phase, where the intrinsic 10A complex is formed and generate 10A and then thrombin, the propagation phase is really decreased in patients with factor VIII deficiency. So we will go deep in that, and we will see how factor VIII can really regulate this tenase complex. Indeed, factor VIII is a cofactor of factor IX, which is a serine protease which activate factor X. But its role is not stopped just by bridging factor 10 to factor IX, but factor VIII also regulates the activity of the tenase complex. Well, once factor VIII is separated and liberated from von Willebrand factor, it becomes activated. This is the go signal for the tenase complex. So factor VIII acts like a on switch for the tenase complex. And when it is activated, it will bind to factor IX with a high affinity. And this binding will stabilize the catalytic site of factor IX. Now, bound to factor VIII, factor IX can more effectively activate factor 10. And as you can see here, depending on the biological conditions of the experiments, the effectiveness, the added value of factor VIII to the tenase complex can be 200,000 times more than factor IX alone. On the other side, if you look at carefully the concentrations of the proteins in the tenase complex, factor VIII has the lowest concentration compared to factor IX and factor X. This also means that as soon as factor VIII will be consumed or inactivated by the APC, then the tenase complex will gonna stop. So factor VIII also acts like an off switch for the tenase complex. And if we summarize all the roles of factor VIII and its regulation effects on the tenase complex, we can say that factor VIII is a major regulator of the tenase complex, even for on-switch and off-switch of the enzymatic complex. But also factor VIII can bridge factor IX, factor X, and stabilize the tenase complex proteins on the surface of platelets and can dramatically increase the effectiveness of the factor Xa generation.
Thank you, Yesim. And now we will look at the second animation, which outlines how non-factor and rebalancing therapies act in hemophilia.
Well, as you said previously, mimetics can also generate fibrin and thrombin, but this is done in another way. Of course, the monoclonal antibodies that mimics factor VIII activity, they can bridge factor IX to factor X, but those are antibodies, so they do not need to be activated or inactivated. So in that way, they are stable in plasma, so there is no this on switch or off switch, the regulatory mechanisms of the factor VIII can bring to the tenase complex. So this is one of the major differences. The other difference, the concentrations again of these antibodies, they are largely over to factor IX and factor X. So again, there is no off switch because factor VIII is consumed. Here, antibodies, they are staying stable in the plasma and the tenase complex is ongoing. And it has also been shown that the fibrin clot structure will be different when it's obtained with mimetics or with factor VIII, natural factor VIII. And what about the rebalancing agents? We have in Europe already 2 anti-TFPI antibodies who are used in different ways in early access or already on the market. TFPI is a protein which is expressed in different ways on the endothelial cell surfaces, but also we have some TFPI into the platelets granules. We have soluble TFPI in plasma, and there is also some in the extravascular area. So these antibodies, they will specifically block the Kunitz 2 domain of anti-TFPI, and by doing this, they will reduce the 10A generation, mainly during the initiation phase and at the very beginning of the propagation phase of thrombin generation. So this means that the activity of 10A generation in the initiation phase will be longer, and the patient will produce more 10A, which can bypass the activity of factor VIII, and we can generate again thrombin generation effectively and have a fibrin clot. And if we look at thrombin generation curves obtained with different rebalancing agents, you can see that the kinetic is pretty different from factor VIII. So the curve shows you the baseline of a severe hemophilia A patient without any factor VIII expression. This is a normal plasma, which represents 100% of factor VIII activity. When you look at emicizumab, the differences in peaks and ETP, peak doesn't tell totally the hemostatic activity of these drugs. And when you compare concizumab or fitusiran, we discussed the initiation phase and the 10A generation during initiation phase last longer with anti-TFPI antibodies. This is what you see with a slightly longer lock time with the thrombin generation curve. And then the thrombin generation is totally fully restored with these agents.
Thank you, Professor Dargo. I think it was very interesting. So you mentioned that the clot, the quality of the clot can be different with different agents. What do you mean?
Well, many years ago, the in vitro studies from UNC, from Alisa Wolberg, showed that higher is the thrombin concentration, fibrin clot gets more stronger because fibrin fiber diameters, they are getting, more thinner, and which makes a stronger network between fibrin fibers. And in patients with severe hemophilia, fibrin fibers, they are thicker, and they are just like spaghetti sitting each other, but there is no this networking which gives the strongness and robustness of the fibrin clot structure. So with emicizumab, there are some studies coming from animal models which tell us that maybe the fibrin clot structure can be less strong and robust and less resistant against fibrinolysis compared to factor VIII.
Okay, thank you. So let's say that hemostasis is not just a matter of quantity of hemostasis, but also quality of the clot.
Absolutely. Absolutely. So, may I ask you what are the issues associated with measuring the hemostatic activity of non replacement therapies?
Oh, yes, of course, being a clinician in the hemophilia field now since quite a long time, I can tell you that we love to measure what we do to our patient. And it's pretty much easy. We now know that it's easy with factor VIII. So when we replace factor VIII, we are able to measure exactly what we are doing because we follow a linear PK. So we give something intravenously and we can follow really, let's say, the fate and the destiny of this protein in plasma. With non-factor replacement therapy, we cannot use the same assay that we use for factor to measure factor VIII. And there is a problem there because we would, as a clinician, we would like to be guided in some situation by measuring what we are doing to the coagulation cascade. And we learned, for instance, with factor VIII mimetics, that one-stage assay, so let's say the PTT-based assay, are completely not reliable in measuring the amount of hemostasis that we are triggering in those patients. Because of the mechanism of action and the affinity to the substrate. So we should move to chromogenic assay if we want to measure hemostatic clotting factor in those patients. But we cannot measure the activity of mimetics in a very reliable way. And so what we are missing is by now some validated monitoring tools. But the main point is that as of today, we have poor correlation between laboratory method that we have and the clinical outcome. Maybe it will come. You mentioned, and maybe you can comment on that, you mentioned the use of thrombin generation. We see that thrombin generation somehow reads what's going on. But what's your opinion on the fact that we can really use day-by-day thrombin generation to read clinical outcomes properly?
Well, these new molecules, they improve thrombin generation. So theoretically, these assays or other global assays, they would be able to show us the global effect, hemostatic effect of these agents. However, we do not yet have the validation, which proves that in multicenter studies, we have some data coming from, single center studies, but we do not have the proof that they are really correlated to the clinical outcome of patients. And this is something that we need to do if we would like to monitor something, because I think we can tell that today we are treating something that we are not yet able to measure.
Yeah, and this can be somehow, I mean, make us a little bit lost in translation sometimes. So to translate really in the clinical field what we are doing in the lab, looking in the lab.
Exactly.
So, Professor Dargo, Yazim, let's discuss what are the clinical implications of all these agents.
Well, let's say that treatments have been tremendously improved in the last 15 years, but can we say that the problem of hemophilia is now over? I don't believe that. So I think we have at least two groups of patients nowadays. So we have young patients who are doing well, who have been grew up with long-term prophylaxis, and they do not have major damage in their joints. And I think with these new molecules, we can say that it's really life transforming, and we can really offer them normal life. So not only, I mean, suppressing bleeding, but normal life. And the other group of patients, they are adult patients who have some major joint in their joint damage, and they are living with the consequences of the accumulated complications of their earlier the disease. And this group, I mean, they have chronic pain, they have mobility problems, they have function problems, social activities. So we have a lot of work, I think, to do on this group. So these new molecules, they promise us normal life. So we can offer right now, so some of the patients, this possibility, but some of them, we need to work more on that, I think. What are your opinions?
Yeah, I mean, you touched something which is important. So, what is normal? I mean, it's not easy to define what is normal, but for sure, what we can do nowadays with some agents and looking at, the therapies, we can somehow provide, I would call it a non-hemophilia life. So, something, of course, if someone has arthropathy, this stay there. But if you can avoid majority of almost all bleeds, this can go into normal life, because usually non-hemophilia patients, people, they do not bleed. But I think we have to be cognizant of what we have in our hands in terms of therapy and how we can achieve that. As I mentioned, having normal levels, so levels in the non-hemophilia range is something that we can achieve and measure with factor VIII replacement. Still, I don't think we are in a phase that we can 100% ensure that using non-factor therapies, we are going there for everyone because of the problem of monitoring in the lab, and also because of the mechanism of action, which is a little bit different. So yes, if we look at different therapies, if we use factor VIII, whichever is the type of the molecule, we can get into the non-hemophilia range. Much harder if we use the standard half-life products, because to get there, we should increase a lot the number of infusion per day, maybe even twice daily, to get into the non-hemophilia range. While with new molecules, we can get, I mentioned already the ultra-long half-life. We now know that we can do prophylaxis once weekly with such a molecule, maintaining such level for almost not all the week, but maybe 4 to 5 days over 7 days. With the rebalancing and mimetics, I do think looking at the clinical outcome, but maybe on in individual basis, some of those patients are really well covered. But it is not for all, and also the fact that we cannot properly measure what is going on in the blood leave us a little bit uncertain in some situations. So this is the scenario, and there are some needs and some challenges still open, like surgical setting, how to manage those patients who are on no-replacement therapy and they need to be in the operating room, or if they experience a bleed, how to manage. I think that you agree with me that we are learning with experience, because with factor VIII you can give some amount, measure the level, and in a way we are really much used to correlate the two. What do you think?
Absolutely. I think the difficulty comes again to estimate the global efficacy of combined therapies. So in case of breakthrough bleeds or surgery, rebalancing agents or mimetics, they are for the moment not good enough to achieve hemostasis with these major challenges. So we have to add some extra procoagulant molecules. It can be factor VIII or inhibitor patients bypassing agents. And then the treatment becomes more challenging, and we are coming back to the how we can estimate the hemostatic capacity of the patients and also how we can monitor it, and these are still unmet needs indeed.
I
And what
agree.
about the women and girls in these new innovations and how their life changed?
Yeah, I think you touched a very relevant point. I think we learned that we had to pay attention to non-severe ones, and especially they are part of this population. For a very long time, I think we neglected them, and women and girls, they do deserve to be, treated as well as their, let's say, severe peers, and so also providing them with prophylaxis when needed, also giving them the opportunity to use also new therapies that we first prove on severe patients, but then we know that the advantage can be enlarged and widely used also for other patient population, including women and girls. So if I ask you, which is your main takeaway from the discussion that we had, and maybe also looking to the future, what would you tell me?
Well, I would say there's a extraordinary period for patients with hemophilia A. So we are coming from standard half-life molecules, which is a huge burden and a limited efficacy. And now we have different, options for patients. Each patient is different, so we can really choose personalized way, the right treatment for the right persons. And for this, we have ultra prolonged half-life factor VIII, which can be measurable and we can know exactly what we are doing with. It will be making life easier for not only patients but also for physicians in surgical settings and also at home treatment. And we have this rebalancing and mimetics, which really tremendously change the quality of life of patients and make the prophylaxis easier. I think those are today messages, and there are still place for improvements in future.
I would only add to conclude that my main message always is that the standard of care is prophylaxis. So whichever is the drug that you use, hemophilia patients, they do need to be treated on prophylaxis to prevent majority of bleed. And looking in the future, just because we are very rich in terms of treatment strategies, the dream could be that getting into the non-hemophilia range when they are young with pristine joints, new generation will never experience joint damage, and we will be good enough to provide them with good quality of life and, let's say, normal lifestyle, because surgery won't be an issue, and also the management of breakthrough bleed will not be an issue, because the quality of the treatment that we are achieving is so high that we are going really to compare them and to get them very close to the non-hemophilia population. So this is my last message. So, Professor Dargo, Yazim, thank you for this great discussion.
Thank you very much.
Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.